at the EHA meeting in this year, we reported our abstract of inotuzumab ozogamicin plus obinutuzumab for relapsed refractory Ph positive ALL or CML in lymphoblast crisis. So we know the outcomes of patients with relapsed refractory Ph positive ALL or CML in lymphoblast crisis are dismal, and some previous studies with chemotherapy have shown outcomes of less than 6 months. Even adding tyrosine kinase inhibitor, the outcomes have not significantly improved for these patients. So we proposed a non-chemotherapy approach with the use of inotuzumab ozogamicin, which is a CD22 monoclonal antibody already approved in relapsed refractory B-ALL and has activity in Ph positive ALL as well, plus Bosutinib, which is an ABL kinase inhibitor, which is approved for patients with CML. The combination of these two drugs may help treat patients with relapsed refractory Ph positive ALL. So we initiated this study, which is an investigator-initiated study at MD Anderson. It is a phase 1, phase 2 clinical trial. We are presenting the data after the completion of the phase 1 part of the study. The primary objective of the phase 1 part of the study was to assess the safety and the MTD. The secondary objective was to assess the efficacy. So we enrolled patients who were relapsed refractory Ph positive ALL or CML in lymphoblast crisis, age 18 years or older, bone marrow blast count more than 5% with adequate organ function. Notably, patients with T315I mutation, which leads to resistance to Bosutinib, were excluded. So the patients received inotuzumab starting in cycle 1. The cycle 1, they received a total of 1.8 milligram per meter square, total dose over the course of 1 month. On day 1, they got 0.8 milligram per meter square. On day 8, 0.5 milligram per meter square. And on day 15, 0.5 milligram per meter square. So the dose was split weekly. And Bosutinib was started for the dose level 1 at 300 milligrams per daily, at dose level 2, 400 milligrams daily, and at dose level 3, which was 500 milligrams daily. And the Bosutinib was started on cycle 1, day 1, and continued until disease progression or toxicity. For inotuzumab, after a patient achieves a remission, the dose of inotuzumab was decreased to 1 milligram per meter square every 4 weeks. So we treated a total of 18 patients in the study with a median age of 62 years, and the number of prior therapies was 1. Median number of prior therapies was 1. The prior TKIs, 61% of the patients had prior dasatinib, and 44% of the patients had a prior ponatinib. 44% of the patients also had more than 2 or more TKIs prior to getting on this clinical trial. So we, in the phase 1 part of the study, in terms of the DLT assessment, we noted 2 DLTs at the dose level 3, which was Bosutinib 500 milligrams daily, and this was both for skin rash, and therefore dose level 2, which was Bosutinib 400 milligrams daily, was assessed as MTD to proceed in the phase 2 part of the study. In terms of the responses, in an intent to treat analysis among all 18 patients, we saw an overall response rate of 83%, 61% CR, 22% CRI, and our CMR rate, complete molecular response rate, was 10 out of 18 patients, so 56%. The median overall survival of the study was 15.4 months, and the median event-free survival was 8 months. So overall, the study shows that inotuzumab plus Bosutinib is a tolerable combination and is safe for patients with relapsed refractory Ph positive ALL. MTD of Bosutinib was 400 milligrams once daily. Our overall response rate was 83%, with 56% achieving CMR. And I should mention that we did not observe any VOD in this study so far. 6 patients subsequently went to an allotransplant. And again, we have not noticed any VOD in the study so far. So that's the brief summary of the study we presented at EHA.